tough for me to do now your presentation for two reasons. First, because it's after lunch. Nobody wants to be here after lunch. And second, because it's after James and Lucy. So nobody wants to be here after James and Lucy, because you always make yourself a little bit of a fool. I heard that you guys have been a week in Rome learning about heart failure and biomarkers. So let's have two patients here. Patient number A is a male, 65 years of age, hypertension, dyslipidemia, acute myocardial infarction in 99, ICD implanted in 2005. Now comes to the clinic with New York Heart Association class 2-3, third heart sound, no rails. We do echo regularly, routinely, ejection 11 to the end-diastolic diameter 69, which for those who are not accustomed to this, normal values would be maximum 55, ejection fraction 16%, which is severely depressed. We do an EKG that you can see here for the non-cardiologist. Let's say that this is a sinus rhythm with left bundle branch block. We have hemoglobin 12.1, slightly anemic, renal function normal. So this is one patient that I see in my clinic. This is another patient, number B. 58, smoker, inferior infarct in 2006, ICD implanted, class 3, third heart sound, no rails, 73 millimeters in left ventricular end-diastolic diameter, ejection fraction 20%, ECG, as you can see here. Let me summarize for you. It's a sinus rhythm with LVDP, left bundle branch block, non-anemic, slightly renal dysfunction with an eGFR of 55. So this is what we get most of the times when we visit patients. We get clinical history, echo examination, ECG lab, and the the echo. So oftentimes we do have one biomarker, oftentimes we do not, and we have to try to assess what's the risk of this patient in the short and the long term. So I'm going to ask you, which is the risk of this patient? What is the prognosis? It's a similar risk for both. Patient A has worse prognosis, patient B has worse prognosis, I need more. Okay. The first year residents, they always need more. So we say, let's start doing things. So what did you say? Who? Hands up, say number one. Number risk. Number two. One person for each. Number three. Patient B has worse prognosis. Number four. Yes? You need more. Okay. Yes, today we do have more, we do have biomarkers, and we did for these patients NT-proBNP ST2. NT-proBNP was slightly above what we consider the optimal cut point, which is 1274. The optimal cut point would be 1000. ST2 was 25. This patient had a good clinical outcome. He works New York Heart Association class 2. After 3 years, no more hospital admissions. ST2 25. The other patient, similar NT-proBNP, ST2 65, admitted 3 times in 4 months, sudden death at night. So these two patients that are clinically quite similar, quite decompensated because both of them have third heart sound, which suggests that this heart is suffering quite a lot. Ejection fraction is very depressed, left bundle branch block. So these two patients have quite different outcomes. And in order to achieve this, we needed something else that our routine assessment, and these were biomarkers. In this case, NT-proBNP was not enough, and the biomarker that actually provided us the information to identify whether a patient was a high risk or a low risk patient was ST2. So I would say we have 2 biomarkers here, NT-proBNP above 1000 and ST2 above 35. That would be the cut points for these patients to consider. Biomarkers are indeed an area of explosion. Some call them a tsunami. Okay? and I'm referring to Jim Janus's editorial in JACC Heart Failure a few months ago. The number of papers published in PubMed on biomarkers is growing, but particularly in heart failure biomarkers. Look at this. I mean, this is from the year 1990 to the year 2010. So it's exponentially grown up to the peak Everest almost. So this is an incredible number. Are all these papers valuable, useful? That's for every one of you and for us to determine. But what is a reality is that there is interest for biomarkers, that biomarkers are here to stay, and that we need to choose the biomarker that fits best our patient. As Jim said before, when we evaluate novel markers for cardiovascular risk, we need to be very careful. And what we did 10 years ago is not useful right now. And we have this statement from the American Heart Association published in the year 2009. And look what they say. So both measures of discrimination and accuracy should be reported. The clinical value of a marker should be addressed by its effect on patient management and outcomes. In general, a novel risk marker should be evaluated in several phases, including initial proof of concept, prospective validation, in independent population, documentation of incremental information when added to a standard risk markers. So we need to document incremental information when added to standard risk markers. This was published in Circulation 2009. It has not been implemented very routinely in many of the studies, but I believe more and more people are conscious about this. And I have to highlight this editorial published by Jim and Roland van Kemenade, I would say 15 days ago. It's already E-PUB publication. The importance of rigorous evaluation of comparative biomarker studies. This is important because otherwise we are not going to be able to incorporate novel biomarkers in the market. 3 issues: discrimination, calibration, reclassification. As Jim said, discrimination allows us to determine if a new model, a new biomarker, provides significant value above and beyond established models or established markers. Calibration is just telling us that our model, the old one and the new one, are properly calibrated in the sense that they can be compared. And reclassification gives us a number, which is a percentage of patients that go from the gray zone towards a low-risk group or towards a high-risk group. If you imagine an NRI of 10%, this means that there is a 10% of patients that you don't know in which risk were before, but after the addition of the biomarker, this 10% of patients is becoming a low risk or is becoming a high risk. And this is very important. You want this to be significant and you want this to be relevant. Okay? Another issue, and when we're talking about biomarkers and particularly about multi-marker approach, this is a fundamental paper that you have to read in JACC Heart Failure just at the beginning of this year. Bromwell said, these are the biomarkers you need to be considering in the present and in the future. Myocardial stretch, myocyte injury, matrix remodeling, inflammation, renal dysfunction, neurohumoral activation, and oxidative stress. Are we actually looking to all these factors? Let me explain you how we approach this issue based on this chart proposed by Jim Bromwell, and how we do almost approach to all these areas. We have developed a BCN, a Barcelona Bioheart Failure Calculator, with the aim of using a multi-marker strategy in a cohort of patients, ambulatory patients, attended in a heart failure unit. We implemented 3 biomarkers, NT-proBNP, high sensitivity troponin, and ST2, on top of a very comprehensive clinical model, which I'm going to show you exactly which are the variables that we use. And the variables that we put in this clinical model are all the variables that the clinicians faces with their patients in their day-to-day practice. These are the variables that I put in the first 2 examples. I want these biomarkers to be better than this comprehensive clinical model. First of all, NT-proBNP is a marker of stretch. This is a marker that was incorporated. The first to play is the first to stay, and we cannot do anything today without NT-proBNP. As you know, it's useful for prognosis, for short and long-term prognosis, Janucci and myself participated in the ICON study, and we demonstrated that it's useful for short-term prognosis. A value of 5,000 nanograms per liter was useful to identify patients at very low risk, 5%, and patients at very high risk, 18%, of dying after 60 days of coming to the emergency department. So 5,000 for acute prognosis, around 1,000 nanograms per liter if you are measuring NT-proBNP for long-term prognosis. And this comes also from Jim's Pride study. If we look to other studies, like the BALHEF study, again, around 1,000 nanograms per liter is the long-term prognosis for NT-proBNP. So we have here one marker of stretch that's been already incorporated in guidelines, and we use in clinical practice. When we assess NT-proBNP together with ST2, we get these curves whereby high NT-proBNP, high ST2 give us the worst or the sickest patients. Look at these patients after 1,500 days. There's only 25% survival, and here when both are below the cut point, almost 90% or 85% are survivors. So we go from 85% of survivors to 25% of survivors, and there are the intermediate groups as shown before. High sensitivity troponin. Why do we want to incorporate high sensitivity troponin in a model? Because conventional troponin was not very useful to identify small areas of necrosis, but high sensitivity troponins identify single cardiomyocytes that die, and these myocytes may die because of microvascular obstruction, because of myocardial stress, whatever. This is a marker of necrosis that is elevated in patients with chronic heart failure. We demonstrated there is a very good correlation between HS, troponin T, and New York functional class. So the higher the functional class, the higher the value of high sensitivity troponin T. And again, we demonstrated that the combination of troponin T and ST2 is useful. So when both are low, we have very good prognosis. When both are high, we have very good prognosis, and we have either above cut point, we have intermediate prognosis. So again, combination of two biomarkers is better than one single biomarker alone. ST2, what else can we tell about ST2 that you don't know? It's a marker of fibrosis under modeling. So we have the marker of stretch, the marker of necrosis, the marker of fibrosis. What is fibrosis to the heart? This is fibrosis to the heart. These are scar areas surrounded by healthy myocardium. This scar area here, which is a small one and maybe due to hypertrophy, maybe due to microvascular obstruction, whatever, is producing left ventricular stiffness, and this produces desynchrony and systolic dysfunction, and at the end, systolic or diastolic heart failure. In other words, pump heart failure. But cardiac fibrosis induces tissue heterogeneity. This means anisotropy, re-entry, and arrhythmias. So surrounding this area of scar, we get all these re-entrant circuits and arrhythmias, and these arrhythmias produce sudden death. So fibrosis is the main cause of, or is the main pathophysiological pathway of heart failure and pump failure and of sudden cardiac death. As shown before, there is a good correlation between ST2 and New York Heart Association, as Jim showed you before. Again, as ST2 levels increase, so does risk. So this is the lowest decile, and this is the highest decile, and one-year mortality exceeds 50% in the highest decile, and this is quite relevant. This is data that has already been shown by Jim before. Is from the 10 study. These are the results of the Kaplan-Meier curves for ST2 divided by tertiles. The higher the tertile, the higher the risk. And this is the combination of ST2 plus NT-proBNP coming from a chronic heart failure cohort, which includes transplant-free survival. As far as ST2 and sudden cardiac death, it has already been alluded. The music study which is a prospective multi-center study designed to evaluate sudden death predictors in ambulatory patients with congestive heart failure. 992 patients, class 2-3. This is a multi-center study in Spain, and the main outcomes are these ones. ST2 and NT-proBNP low. This is a 3-year follow-up. ST2 and NT-proBNP low, 4% risk of sudden cardiac death. That's what I said before. It's just about a little bit more than 1% risk of sudden death per year. ST2 and NT-proBNP high, almost 75% risk of sudden death, which means 25% risk of sudden death per year. So if these two are high, 1 out of 4 patients are going to die of sudden death per year. If these two are low, 1 out of 100 patients is going to die. In Spain, we're having a crisis, which is not an easy one to handle, and we're having 25% of unemployment, and we're having a credit crash and no money. So my hospital director, the first thing that comes to me every month is, you have a limited number of defibrillators and CRTs that you can implant in your patients. So I want you to choose the right patients where you want to implant the defibrillators, because we need to refine our criteria. The MADIT criteria would say, after myocardial infarction with low ejection fraction, you put a defibrillator, protects the sickest patients, but at the same time, we are putting a number of defibrillators that are never going to fire. So we need to identify the high-risk patients. So if we're having cost constrictions, we want to use our devices to the patients that really need them. So it's much cheaper to measure these two biomarkers than to spend 25,000 euros in a defibrillator. So this is something that we are considering, and hospital directors and clinic directors are starting to take this into account. I'm not going to go any more into these slides. I think you have seen this 25 times today. So this is the weird paper. If nobody, if there's anyone in this room who doesn't recognize this, you guys have a problem, huh? The benefit of measuring ST2 and the value of eplerenone when it's low. There are no differences between placebo and eplerenone as far as left ventricular and diastolic volume index. When ST2 is high, then you do have a reduction in remodeling with the use of eplerenone. One important thing of ST2 is that it's not affected by renal insufficiency. In chronic heart failure, we do have patients often with renal insufficiency. We often see patients with eGFR below 60. And I have to say that below 60, nearly 50% of our patients have this light to moderate renal insufficiency. What do we see with NT-proBNP? That at this value of 60, we have this exponential rise of NT-proBNP that makes it difficult to understand the real value of the NT-proBNP in the context of the cardiac dysfunction. So it is more of a raise because of the renal dysfunction, or is it due to the cardiac dysfunction? This does not happen with ST2. This is 60, the values at 60 are similar to those at 90 and 120. Only at the very, very end, with eGFRs that are almost close to dialysis, at this very end, we are starting to have a rise in ST2. These are class 2-3 heart failure patients. This line is very stable all throughout. Yes?
Did you look at outcomes in these patients? I'm curious, if the rise in the worst renal function is actually reflective of underlying heart disease rather than it being a simple accumulation issue.
Well, in these patients, they were all ambulatory patients, and it was not, they were not decompensated in this regard. So they were not congestive patients coming to the day hospital for the compensations, or they were not in the ward. So these are patients walking to our outpatient clinics. When we look to outcomes in this group of patients, we see, just before outcomes, we see that in the worst group of patients, class 3 and 4, which is the subgroup of patients that more often induce renal dysfunction, there are no differences for ST2 in normal, moderate dysfunction and severe dysfunction of kidney. values, and by contrast, we do see an increase of NT-proBNP in those patients that have worse kidney function. So I believe that this is a study that's impressed now in the Journal of Cardiac Failure. We have in this paper you will see many other biomarkers like cystatin C and many others to compare all of these values. But the main message today is that in ambulatory patients with heart failure, you can measure ST2 and you don't have to do any adjustment or any modification of your assessment when your patient has renal dysfunction. Is this what you were asking?
Yeah, I mean, I was mainly asking whether, you saw that mild influence, the R value was so minimal. But, the question is when you get down under a GFR of 30, if that higher ST2 is actually predicting a higher risk, actually, rather than it being related to just simple accumulation from renal function. So, is the risk of an elevated ST2 in someone under GFR 30 worse than an elevated ST2 with the GFR 90, for example?
The numbers here are smaller numbers. As you can see, the values from 0 to 20 is a small number of patients, but certainly these are the sickest patients. Yes.
Do you know the impact of eGFR on galectin-3 levels?
The impact of eGFR on galectin-3, I could measure this in our cohort. We have not measured, and I don't have that data. I'm not sure if Jim can answer this.
Yeah, it's fairly minimal, but when you look in survival models, the factor that seems to knock galectin out of the model most often is renal function. And it may be because galectin reflects fibrosis not only in the heart but also in the kidneys, where it's actually a very good renal fibrosis marker. So it's unclear if the weakness of galectin is simply because of the fact that it's handled renally, or if in fact an elevated galectin, when a person has elevated markers of renal dysfunction, is actually reflecting kidney rather than heart failure.
Yes. So it's good. We have a marker of fibrosis that's quite stable in this comorbidity that's very frequent in heart failure. Why ST2 and not GAL3? If we're measuring fibrosis, why do we measure ST2 and not GAL3 in our calculator? Well, we tried to answer this. You know that GAL3 is a beta-galactosidase binding glycoprotein that stimulates through fibroblast differentiation and at the end produces fibrosis. Okay, this is a fibrosis biomarker. Is this a good biomarker in the context of congestive heart failure? When we assess quartiles from ST2 and galectin-3 in this univariate analysis, we do see differences in the two biomarkers, and the highest quartiles provide the worst outcome. So these were the kind of analysis that we would do 10, 15 years ago. And with this analysis, we would say the two biomarkers are equally useful. Okay? What do we do now? And what we proposed in this manuscript published in JACC, we compare discrimination, reference model with GAL3, model with ST2, calibration, and reclassification. Jim did such a great job that you probably already have the numbers. So the reference...
But they're your data, Tony.
The statistic is 0.757 in the reference model, 0.76 in GAL3, 0.77 in ST2. This is statistically significant, so we are, by adding ST2 to the model, we are providing relevant benefit to risk stratification. When we look to calibration, this is our background, our reference. If we go to the model with ST2, calibration is better by all standards in this model than in this model. And more importantly, when we do look to reclassification, then we go to the NRI, which is the net reclassification index. GAL3 reclassifies 0.7% of patients, which is not significant. And some of the patients are reclassified wrong. So they go in the negative direction, minus 0.01. By contrast, ST2 reclassifies almost 10% of the patients. So 4.4 to those which at the end will decease, and 5.0 to those that at the end will be alive. So in this gray zone in the middle, ST2 reclassifies half of them towards the group of very high risk who will end up dying, and the other half to the group of very low risk who will end up surviving. This, we believe, is a substantial increase, having into account that the reference model is already very comprehensive. This is something that's not very often reported in the literature, which is a head-to-head comparison of two biomarkers. So we have here GAL3 versus ST2 for all-cause mortality, GAL3 versus ST2 for cardiovascular mortality. If we put GAL3 as a reference model here, we want to check if ST2 would provide any benefit to GAL3, and as you can see, ST2 is significantly better as far as discrimination, calibration, and reclassification, both for all-cause mortality and cardiovascular mortality. So I believe we are providing here very solid statistics that give us arguments for the use of ST2 as a fibrosis biomarker in chronic heart failure against GAL3. This means that GAL3 should never be used. But this means that in chronic heart failure patients, GAL3 does not provide risk stratification. Maybe in post-infarction or in other cohorts, that's not a story, but in the large group of patients with heart failure, GAL3 is probably not the biomarker we're going to use. So we arrived to this VCN bio-heart failure calculator. What is this? This is a calculator that contains NT-proBNP, a marker of stretch, we said that. HS-troponin T, a marker of injury, we said that. ST2, it's providing us information about remodeling and somewhat inflammation. Good, we're in good shape. Renal dysfunction. In the calculator we use EGFR. Neurohormonal activation. We do not use biomarkers for this, but we use beta blocker treatment, ACE inhibitor treatment. If we treat the neurohormonal activation, in a way, we are measuring indirectly the neurohormonal activation. So we are assessing with this calculator almost all of the star arms that Brownwell was proposing us, except for oxidative stress, where we don't have a good biomarker right now that can provide us solid information. Renal dysfunction, what do I use? I use Cockcroft Gold, MDRD4, CKD-EPI, use whichever you want. In this paper, we demonstrated that Cockcroft was probably better than the other two, but very recently, since creatinine has been standardized to the IDMS system, so probably it's not so good anymore, so use MDRD4 or CKD-EPI. It's irrelevant. Do I use EGFR or the new, more sophisticated cystatin C biomarker? Well, we wanted to demonstrate if cystatin C was the marker we needed for renal dysfunction, and we recently published that cystatin C has very limited value over EGFR for heart failure risk stratification. So this is a marker that has a cost that we do not do regularly as opposed to EGFR, and the value is very limited. So my suggestion is that we need to reduce costs. Let's keep it simple. Let's go to EGFR. This is the multivariable cost in the calculator. So look at this. Age, female sex, etiology, ejection fraction, New York Heart Association functional class, renal function, diabetes mellitus, treatment with ACE inhibitors or ARBs, treatment with beta blockers, sodium, hemoglobin. This is what we use in our day-to-day practice. There are nothing else, guys. I mean, this is all you can put in. If we add these three biomarkers, NT-proBNP, ST2, or troponin T, these three biomarkers are very strong. And they are so strong that conventional and classic risk stratifiers, they are not anymore valuable. For instance, diabetes is not anymore. EGFR is not anymore. Ejection fraction is not anymore. That's surprising, and that's because of the strength and the value of these new biomarkers. However, we kept them in the calculator because we believe that some of these markers are so classically used by the doctors, by the clinicians, that they will continue to use them for a while. And this is a very complex table of performance, but I just want you to concentrate in the models, and we will go to the reclassification. Model 1 is the clinical model with the 11 variables here. This is going to be our reference model, okay? This is going to be the reference model. And then we have model 2, 3, 4, and 5. Model 2, we combine NT-Pro and troponin-T. Reclassification 4.2%. Model 3, NT-Pro, ST2, almost 10%. Model 4, troponin-T and ST2, 14%. Very interesting. NT-Pro, troponin-T and ST2. So we were thinking that the three biomarkers would always be better. And to our surprise, when we put the three biomarkers, it's worse. So the take-home message from this table is that ST2 and troponin-T appear to do better to risk stratify these patients on top of all these variables than the combination of the three biomarkers. So if I had to choose right now from this data, and my clinical director tells me, you will never use three biomarkers, Tony. Give me two. Right now, I would choose high sensitivity troponin and ST2.
So what do you think the BMP reduce the efficiency of reclassification?
Wait, we don't have a clear answer for that, but we believe that these three biomarkers, which apparently are approaching different pathways, may have some degree of overlapping. And therefore, when you are having a troponin-T, which is a necrosis biomarker, eventually when you have a very severe stretch, some of these myocytes may die. So as a consequence of the stretch, you have death of the biomarkers. And also fibrosis may have an indirect effect on stretch. So we believe that in a way, NT-proBNP may be redundant in this combination. Therefore, as David said before, today we want to use ST2 on top of NT-proBNP because what we have. What are we going to do tomorrow, in 2 years from now? That the other two biomarkers are stronger. It's going to be difficult to convince our colleagues, but these two are stronger. So this is a web page calculator that we hope that this paper is accepted soon and we can provide to you for your use. We have clinical variables, treatments, and biomarkers. You put all these values in the clinical variables, in the treatments, and the biomarkers, and then you get these curves, a model without biomarkers, a model with combined biomarkers, and you will have risk at 1, 2, and 3 years, risk of death, and here you have life expectancy without biomarkers and with biomarkers. Let's have a look to this. This is a 68-year-old patient, male, class 3-4, sodium 138, eGFR 50, hemoglobin 12.5, ejection fraction 35, on diuretics, on statins, beta blockers, and ACE inhibitors, so we are treating the patient quite well. When we only evaluate the patient with these clinical variables and treatment, we get the blue line. This is the blue line. This means 9% risk of dying at 1 year, 19 at 2 years, 29 at 3 years. Life expectancy 6.3 years. When we put the biomarkers, troponin 20, ST2 70, NT-Pro 2000, we get the red line. This red line is worse, and this patient now has a life expectancy of only 4.5 years, and the risk at 1 year goes from 9 to 14%, from 19 to 28, from 29 to 42. The beauty that we think this calculator has is that it doesn't need the three biomarkers to work. You can use it with 1, with 2, with the 3, or with any combination of the 3.
So if you leave out NT, run the model
If-
with a higher,
if you-
higher than run the model.
If you, it depends. I mean, there is
But it's just one.
there is a formula in the background that makes it run, and if you only have NT-proBNP, it will give you the value, and it will say, instead of saying plus combined biomarker, it said plus NT-proBNP. Yes.
the matter will be that we are not all using troponin T.
If you don't use it, you don't put it.
But have you the simulation with troponin I?
Well, actually, we just published last month a paper in Clinica Química Acta comparing high sensitivity troponin T and contemporary troponin I, and it appears that troponin I is much worse than troponin T. In our hands.
Even from the assay that we use?
We did the Siemens assay. You have this paper published already online in the PubMed. So that's why we decided to go to troponin T.
And same comment from the NT-proBNP and BNP.
Right. We did not have BNP. We had availability for NT-proBNP. In Europe, NT-proBNP is mostly used as compared to BNP. Certainly, I would say there shouldn't be no major difference because NT-proBNP or BNP are interchangeable. But as far as troponins, we evaluated troponin I, and in our hands was better troponin T. As far as fibrosis, we evaluated VAL3, and in our hands is better ST2. And as far as renal function, we evaluated cystatin C, and in our hands is better eGFR. So this is the calculator that right now we believe it's more accurate. We did an internal validation with 1,000 bootstrapping, and this is the weakness of the calculation of this calculator because we didn't found a cohort with all the clinical characteristics and the biomarkers to validate this one, and at the present time with an internal validation. And as you know, Jim, this is always difficult to publish because when you create a model like this, all the reviewers want external validations. Let me give you two examples. This is the same patient, okay? The same patient. I'm just going to change the values of the biomarkers just to show you how extreme this can go. Troponin 14, ST2 30, NT-proBNP 900. Without biomarkers, the blue line, risk 21%. With biomarkers, the red line, risk 9%. You cut it in half. And why? Because these biomarkers are low. In this case, we have the three biomarkers, you may have just one. Life expectancy from 3 years to almost 6 years. High biomarkers, the same patient, okay, 21, 42, 59, 29, 42, 59. With high biomarkers, 70, 95, 2500. The risk goes up by 15% here from 42 to 68. Look that this patient at 3 years has almost 80% risk of death, and this patient has only 32. So in this case, the red line with biomarkers goes much above the blue line, and this patient without biomarker has a life expectancy of 3 years, with biomarkers just 2 years. Yes.
So this is the kind of patient that you prioritize, for example, the CRT. I mean, this is very interesting, but how does that...
This one.
Yeah.
This is the kind of patient that when you see this, you prioritize for multidisciplinary heart failure clinic with heart failure specialists. And this maybe is a patient that's quite stable that you would send to a general cardiologist for a continuous follow-up. Okay? This may need a CRT or a defibrillator maybe, but you want a subspecialist in heart failure that keeps a close follow-up to this patient.
I'm sure that we might find a lot of interest for our daily practices. So are we able to really use these
No.
algorithms, or is there some
No,
pattern issue?
this calculator will be free on the web whenever we have the publication,
Yeah.
and there is an application for the smartphone that's also ready, and it will be available when the paper is published. So both for Android and iOS. So any clinician will be able from their smartphone to calculate easily the risk and the life expectancy of the patient. Yes.
So I agree with using GFR. Did you also look at blood urea nitrogen as well?
Yes.
And it did not
and it
remain.
did not remain. We checked atrial fibrillation because it's also very often it did not remain. We checked at the end, we checked 23 variables. We did 23 models, and we selected for the calculator these ones that were the only ones that were significant. So, what we like use of ST2? We started to use ST2 in the beginning of last year. It's been slow. It's been slow because clinicians don't have the habit to order for the biomarker, because we don't know exactly when to use it, and because we don't have a turnaround time that's clinically useful. So again, we want the point of care. We assessed.
Thanks for the added question.
We assessed so far 338 patients, most of them ambulatory, which is 209. Median ST2 in ambulatory patient 42.3. In green, hospitalized patients, we did 129, median 62.2. This is a dynamic biomarker. There's no doubt about it. It's just preliminary data that I wanted to share with you. And from this, we need to elaborate more how we use it in our day-to-day practice. We assessed in this very small cohort and preliminary ST2 versus NT-proBNP, and mortality at 3 months was good ST2 and was superior to NT-proBNP. When we combine death plus hospitalization at 3 months, NT-proBNP appears to be superior to ST2. We think this is preliminary data. There are only 17 events. This is just internal data for me to show to a group of friends. This is non-published data at the present time. New avenues. There are a lot of new avenues that we are exploring. For instance, ST2 is useful for reverse remodeling in heart failure. Is there a place for measuring ST2 in reverse remodeling? Well, we assessed when you're in the clinic, you get your patient with heart failure, and you start to uptitrate drugs and to control everything. You have to put a CRT and so forth. You measure ejection fraction when you start seeing the patient, and we do one control at 1 year. So we have selected the patients who have an improvement of ejection fraction of at least 15 points. Why 15 points? That was at random. We decided that 15 points was sufficient for a patient to be at risk to become stable. For instance, a patient with an ejection fraction of 25 is at risk, at 40 is stable. And we decided 15 points. What do we see here? We see that median values for ST2 in those who improved were 37, significantly higher to those who did not improve, 43. GAL3, as you can see, 60-60. And NT2 was, NT-proBNP was 1200 against 2200, again significant. So it appears that NT-proBNP and ST2 are useful biomarkers to identify those patients who are going to do reverse remodeling in the long term. When we put all these biomarkers in a logistic regression analysis, ejection fraction etiology, New York Heart Association, duration of heart failure, ST2, proBNP, and GAL3, and we go step by step, at the end, which is the only biomarker that stands up, ST2, heart failure duration, New York Heart Association, etiology, and ejection fraction. So it appears that ST2 may be a good biomarker to identify the subgroup of patients that eventually, during 1 year follow-up, are going to increase ejection fraction, as opposed to those that are not going to increase ejection fraction and therefore are at very high risk of developing events. The aspect ST2 test is already discussed. I'm not going to go too much over it. It's important to have this high negative predictive value. I think this is very important. And my proposal for this card would be not only for prognosis, but eventually, and this is something that I just put here for discussion, eventually for, as an aid in heart failure diagnosis for all patients with dyspnea. So you have this outpatient with dyspnea in a general office. It may be obesity, it may be respiratory. So sometimes, very often, is anxiety. If this is negative, we are in a pretty good shape. And even eventually, this could be a proposed algorithm. So if you have suspicion of heart failure, you do ECG, chest X-ray, and the clinical suspicion. With ECG, chest X-ray, and suspicion, you can have the Framingham and the ECG. Framingham is negative, the ECG is negative, you don't have heart failure. If one of the two is positive, then a tentative algorithm could be this one, ST2. If it is negative, reassess, but probably you don't have heart failure. If it's positive, go for an echo and so on. This is just hypothesis generated. This is an algorithm to try to find a place to the aspect LF that I think is interesting, but we need for prognosis quantitative data. And probably as an exclusion for diagnosis may be good in those patients where we have doubt about where the dyspnea comes from. And this is all. Thank you very much.
Questions for Tony? Okay.
Congratulations for your presentation, first of all. I was wondering if you notice with the Racing modeling you observed that any improvement in the quality of the life of the patients you checked with the multiple biomarkers. I mean, the NIA class was downgraded or just like that?
We have not checked. These numbers we did yesterday or the day before yesterday to have some hints for you to discuss and to, it's more like we want to continue exploring the value of ST2, and this just popped up in the S.p.A, so we decided to show it to you. There is the whole statistics to be performed behind this, but I think it's a good concept that ST2 may, since it may also be useful to determine negative remodeling from myocardial infarction towards heart failure. What about if we assess it the other way around? When you have heart failure, the first time you come to your clinic to determine which patients are more prone to have reverse remodeling, which is something that we do see quite often.
And Dr. Bates, you showed a very interesting example of two patients that looked clinically identical, and then ST2 made the difference. If you would have had this information prospectively, would that have made a difference in treating the patients and maybe saving his life?
In these patients?
Yeah, what you just showed.
Yes. I always say the same. We, first of all, are doctors, and with all the tests that we order, we make decisions. So when I ask for a biomarker, it's not just to have it, it's just to make a decision with the biomarker. And we do have a very structured heart failure review. If I have a high biomarker, in this case a high ST2 value, that puts my patient in risk, I connect this patient to the heart failure unit, and we see this patient regularly. If it has to be seen weekly, until we believe the patient is stable, clinically and biochemically. And this happens for those patients who have high potassium. If the patient has high potassium, I want the potassium to make a decision. I want the ST2 to make a decision. And the decision is pretty much keep an eye close to this patient, look if there is residual ischemia. Sometimes these patients do have ischemia that needs to be treated. Sometimes you need to reconsider treatments. Sometimes you need to reconsider CRT. Sometimes you are worrying about putting or not a defibrillator. It's now the time to consider this is a high-risk patient. I'm going to look to this patient. There are many decisions that the biomarkers aid you in making. So I think a biomarker like ST2 makes a doctor a better doctor.
In parallel with the advancing biomarkers are coming on, I guess, do you see an equivalent advance in parallel treat classic anti-cases inhibitors, beta blockers and all that? Are there novel treatments coming out that also improve the quality of life of the patient, as well as being able to guide that, and also the therapy of top-end isn't coming out.
There are treatments coming out in the past 2-3 years. So we have had a new class of agents useful for heart failure, ibabribine. Ibabribine is an IF blocker which controls heart rate, and it has been demonstrated that prolongs survival in patients with heart failure. This is just 2 years out from here. So we are now using this, I think, more in Europe than in the US, but it's already in guidelines. We have new drugs coming out that may be useful. Ranolazine. Ranolazine is an calcium modulator that is going to be useful for angina and heart failure. There are plenty of trials going on that are going to help us to make our patients prolong their life. This, in addition or in combination with other devices and mechanisms that we have. So we do have now CRT for synchronization. We have defibrillators for the risk of sudden cardiac death. But if this patient has remodeling with a moderate to severe mitral regurgitation, we now can put a mitral clip. Mitral clip is an endovascular procedure that can control this mitral regurgitation. So there's plenty of things that we can do to our patients with heart failure, in addition to beta blockers, diuretics, and executors.
I will just go back to my comment and invite to try the model on troponin I or BNP, because till now it's linked to only one manufacturer, which is Roche. And Roche is not universal, so we should have. I
Don't tell them that.
Can we take over with that? The problem is that we don't have troponin.
And I don't have troponin T.
No, yes.
But you can use the calculator without troponin.
Yes, the calculator can be used with NT-proBNP and BNP. We know that we have the impact of kidney function.
No, but for, you can use with only one marker, and the calculator uses different models. For instance, the beta coefficients for the number of each model are different. For instance, if you have the 3 biomarkers, you don't need nominal filtration rate, you don't need ejection fraction, because it's the same. And the calculator doesn't. If you only have one biomarker, you use this one. I think if you have BNP, probably you can more or less convert to NT-proBNP, more or less. But the accuracy of the calculator will be not the same. Obviously, if you have a patient with high BNP and you compare with the calculator with a patient with low BNP, the rest will be higher, but the accuracy of the percentage.
This is a weakness of the calculator, and we try to overcome this weakness by comparing troponin C and troponin I. And I invite you to look to this paper, which I can send to you the PDF if you wish, because certainly the values were significantly better for troponin C. And as far as NT-proBNP, we didn't contemplate BNP because in our environment in Spain and in France and in most of European countries, NT-proBNP is the most used natriuretic peptide. But yes, indeed, this could be done and could be tested.
I think that on a pure scientific basis, if you consider the recent data of the cardio hormone check or the demonstration of less cross-activities between NT-proBNP and the pro-peptide fragment, the prognostic value of NT-proBNP is higher than the BNP. We have several data in that just to get a more universal.
Well, but Damien, the strength is that we've got ST2. So.
Yeah. That's the only one that I can run.
Exactly. Go ahead.
Possible to use Z values, you calculate the Z score, you eliminate the errors. You can normalize the values, and then you will come to the Z value in model.
I don't understand the question.
Yes. So when you compare apples to pears, then you can use the Z transformation, and the Z transformation will normalize
And
then you run.
and
So
we're-
the
we're-
level is high with one method, you'll be high with the other. Because if you get down immediately zero, then it's +3.
You're proposing this in the case we put BNP2 or?
Yes, you could put it in the tool, then you put the zeta in the tool, you make it independent of the method. Yeah, like the 6-4. What did you
I understand you.
We use this notation of the system in the original career value for studying Reynolds function.
You do that also. The problem is
It's
the
Well,
calculation.
is
The calculation.
for the comparison in the study of the model
Yeah.
probably is relatively easy.
Mhm.
But I'm not sure from the point of view of the construct of the calculator.
For-
You need one beta, and even if you standardize the values, the betas will not be the same for one or for the other.
So to do this statistical analysis, which we did with the Statistics University in our department in our university, we took the Seattle half-failure model and the Framingham score, and we developed an algorithm which would use this background from already settled scores that are up and running. So we are actually modifying algorithms that are validated for prognosis in our population.
Well, if there's no additional questions right now, again, I want to thank Tony for an outstanding presentation.